master's in couple, a master's in couple and family therapy, and a PhD program in medical family therapy. And I actually got interested in hoarding and clutter through a nonprofit that I was part of from a while back in the state of Washington during my doctoral program. So a lot of my interests in aging and geriatrics and caregiving certainly have kind of morphed into the caregiver wellness and dementia space. And certainly my involvements in the Geriatric Education Center, the work with Marla on the Geriatric Workforce Enhancement Program grant. Certainly we've talked about the 4Ms and safety in the home and work for older adults to remain safe and aging in place. But hoarding and cluttering is often a topic that gets overlooked, especially during assessment and intervention and even screening in usual care. So I thought this would be a unique topic that we can share today. I know for fall risk especially, or for those who are homebound and isolated, especially post-pandemic time and phase, this has been a popular topic. So prior to 2020, if you were to ask me if I were to talk on hoarding a lot, I would say there's probably those days are kind of dwindling, and now post-pandemic it's become one of the hot button topics out there. So here we are, and we're back. I'll just give kind of the overall objectives for today's talk. Again, it'll be kind of three pretty clear-cut objectives, just talking about the diagnosis, treatment strategies for hoarding disorder, talking about alternative options for treatment than a forced clean out, and ways that we can address for caregivers and older adults around hoarding. And I'll talk a little bit about the generational differences that we're seeing as well in this topic. As I've talked to many that do clean outs in the community, and as well as providers, where we see generations, earlier 20th century, that, the meaning of items and family significance and historical history, the younger generations have different views on the importance of objects and their relations, not only themselves, but for family history as well, too. So some interesting disparities around that. So, but before I jump into it, maybe for those of you who want to use the chat, what would be kind of a word or descriptor that comes to mind when you hear the word hoarding? So when someone mentions there's hoarding going on, or just imagining a house that's hoarded, what's a descriptor adjective word that immediately comes to mind? Feel free to put it in the chat without even overthinking it. Okay, we got one: dirty, expectation, falls. Right on point with that. Isolation, mental health issues. Yep, absolutely. And I think many of you are even probably being kind. A lot of people out there say, dirty, disorganized, messy, unkept. Again, pathology, co-occurring issues. Yep, non-essential things. Very good point. Depression, absolutely. So, yeah, all relevant. So I do that at the beginning because, really thinking about the shame of this topic, and for, those who have hoarding or cluttering problems for a while, and what comes up, it really accumulates things over time. And you really have to kind of tiptoe in conversations with this population, especially those who have accumulated things for years, if not decades, because on a certain spectrum of people with hoarding, they will rationalize that things not only are to be collected, but there's no problem lying underneath it. So not all people that have hoarding disorder realize or even recognize it's a problem. So the DSM-5 definition in DSM-4 and previous, this was linked with anxiety disorder spectrum. And specifically within obsessive compulsive disorder. There's obviously a big debate, as in with all organizations, where the IOCD organization said that hoarding really needed to be a separate category altogether, because it's different than your obsessive cluster or your compulsive cluster of symptoms, that it takes into the home account, but other traumas that take place for persons who acquire this. So really the top three are what you're looking at, where, if you hit these, really you have to hit these levels. Excessive acquisition of stuff. So this is not where people are once in a while collecting things from the thrift stores or doing online shopping and buying periodically. This is bringing in excessive amounts of clothing or food, of storage items into their garage, their home, their property, taking up an enormous amount of space and not thinking about the utilization right away for the items. And then offset with that is the second part, difficulty discarding. This difficulty really, for some people, is an impossible level of discarding. I can't let anything go. I can't donate anything. I can't give away anything. I shouldn't even put anything in the trash. When we've, I know in previous task force, worked with those that have moderate to severe hoarding, even throwing away a receipt becomes anxiety provoking. I know I can use that receipt or that piece of newspaper article or something for something else in the future. So there's a huge obsession for when people have problems with that. And then 3 is really the living situation space. I know in the chat we talked about fall risk, and that's certainly something that overlaps and correlates, especially in the aging population. I've not been shocked, but when revealed that there's been multiple falls, and then when you ask what a home or walkable path environment's like, they can describe to you that certain sections of a home have quite a bit of clutter. So again, really hitting on all threes. The causing distress or impairment we'll mention, that can vary, but usually that's going to be automatic if you hit those top 3. So how many people that do hoard? These are old references, and these were meta-analyses over a decade ago. This number has really jumped into closer to 5% of the population. That maybe not a diagnosable definition, but really in the 17, 20 million, where there would be cluttering routines that take place, but a decent percentage of that would certainly meet criteria. We have found that's consistent that older people tend to hoard more than younger people. That's a combination of generational differences, but also just the accumulation over years. So that's just kind of the experience of having more and inheriting more. Also, for the inheritance of generations prior, you're accumulating those levels of inheritance, and oftentimes difficult for people knowing what to discard. We have seen discrepancies also with income. They usually with lower income, people often accumulate the items with more worth. Although we have seen families that have struggled in middle to upper class as well. The jury's still out with gender differences. We see even split, and even hoarding has been prevalent in the LGBTQ population. So I think there's still a lot more research out there. If you have very few takeaways from this talk today, this slide's going to be one of your highlights. And I encourage any of you to diagnose your partner, family member, or friend when you leave this slide, or analyze. The differences that go clutter collecting, clutter collecting. So on the left we talk about clutter and the possessions that people have and possess. So this doesn't cause any major problems in the accumulation within areas, no major problems with discarding or acquisition. So you may have a messy room, something that's a little bit disorganized, something that's there that's perfectly fine. Clutter can be cleaned up, based on space, based on visualization. Even with collections, although if collections do get out of hand and become obsessive, it can be a problem. I would say this picture of a basement that someone was collecting cans and bottles, that could be a little bit on the more obsessive side. But, collections mean stuff to people. There's inheritance, there's things that people have that they want to collect over time. It's really on the right side column where, possessions where there's disorganization. There's really no rhyme or reason as far as rhythms that go on with hoarding. It's filling in space for needs, and we'll talk about the mechanisms with hoarding. But really, the three camps that about 98 to 99% of people fall into is either they hoard because there's an instrumental reason for using it, so there's a specific utility they feel they can keep on collecting things. The second thing is for aesthetic. Is that just for the way it looks? It may not have any utility or purpose, but the collections of those things, make them feel good about having that possession. And the third is the fate of the object. So there may be no aesthetic value, but there may be no instrumental value. It's just the purpose and fate that if that goes to the wrong person, it's not in my hands. And so I have to have it and can use it for a reason. Doesn't seem rational, but really that's the vast majority of why people fall into there. So you mentioned in the chat around co-occurring conditions and issues that come up. There is a large comorbidity meaning diagnostic criteria. And again, Randy Frost did this in 2011. His more recent research on literature reviews is kicking up to about 95%. I found for anyone I've worked in my practice or have talked with, especially older adults, I have not seen one patient that has not had a co-occurring issue outside of hoarding disorder, where hoarding has been isolated. OCD, major depression, or generalized anxiety is going to be a significant overlap that you'll see. So if any of you do any assessments and feel like there's any red flags, and not just dig into the hoarding specifications, really look into those mood disorder spectrums to see if there's any problems. But as mentioned, since this was a cluster within the OCD spectrum, there can be high overlap in there. Lesser as far as with specific phobias and substance use. PTSD has a lower rate, but I'll talk about secondary traumas and ambiguous loss that people have around losing a family member, relocation, displacement. That really comes into play when you're talking about hoarding trends. The psychological factors, as mentioned, won't go over this in depth too much, but mental health and emotional distress, people that have poor coping mechanisms, again, the unresolved loss and trauma, it's been reported. So again, the items are replacing a loss of a family member, the loss of a separation. If you have been disconnected from a family member or loved one, there could be some problems with that. Specific beliefs about the attachments or possessions for people. That's something where the feelings or memories, the responsibility that people may have around the object, could be really problematic too. And hoarding behaviors are reinforced over time. So, acquiring things make us feel good. They give us a belief and a reinforcement, even though if there's no value, as we've seen during the pandemic, especially for older adults, these items and just the accumulation have been, replacing the lack of connection with other family members. The problems we're starting to see now is in 2022 and 2023, getting away from that, how people are really challenged discarding things from their home and from their living situation. I can't go without talking about animal hoarding, which is also a big problem. We're seeing this not just in rural areas, but in urban areas as well too, and this is happening much more in the aging population. So there are similarities, but some stark differences. Obviously, as opposed to physical objects with animals and live creatures, you have to know where to place and have safety for the animals if they're being neglected or at risk issues that are going on. Again, on the task force that I worked on years ago in the hoarding project, one of my colleagues did a animal clean out and relocation for a farm that had over 110 animals. There were half of them were cats, but there was also livestock. So now we're getting into a real messy situation of how to handle not just what's happening in a home, but what's happening on actual physical property. It can definitely get out of hand if not controlled. And again, it's not so much that people want all these animals; it's the mechanism of needing to control the fate of where they go, but also the intense need for this population of need connection. If there's no human connection, the animal connection really presents that. And then just some hoarding outcomes during the pandemic. Certainly we see the major rush, I think, for all generations of cleaning out shelves and aisles for food, for those that had housing and food insecurities and instability. This became pretty. I think all of us probably had challenges of maybe overstocking from Amazon at times, but population for those that had problems or I think that's something control or so there's also an increase in what's called panic purchasing that we've really seen coming out of the pandemic. So those in these age groups, being able to purchase things and make sure there's storage and things that are stored away for some time. So again, as you're doing an assessment and initial screening or workup for a patient, if you notice that there are any food insecurities or housing or home issues, don't neglect maybe questions of people not only have adequate amount but the need to almost fill in and have too much. That's really been seen coming out of the pandemic, not just the hoarding behaviors prior to it. So I'm just going to check the chat here. So as far as the safety and health risks associated, this is also super important. I will send out to everyone. I also sent over to Matt that he can push out. There's 5 levels of safety and risk for hoarding in the home. But there's really 2 big camps here, safety and health issues that really go hand in hand. The safety areas, obviously, as a provider, if you're hearing there's fire hazards, blocked of exits in buildings, really home maintenance problems that are going on, you're going to be on an island trying to address this as a provider. So not just bring in psychology, MFT, social work, a mental health, but really try to see how you're collaborating, other resources in the community, and to see about maybe in-home visit or at least talking with family. And I'll go over the levels in a little bit. But people also can have really impaired functioning, health-wise from this. As mentioned, with safety issues come health risks, and we've seen that. Not just animal hoarding, but if there's been expired items, if there's been mold or bacteria, that causes major health problems, not just for the person, but for those that are living in the home, and increased mental health concerns if really this is happening over a series of years, if not decades. So I would say you'll know some of the health, risks as a result of it. People mention this, but the safety we don't address because we may know the home environment. But as far as really the risks that are concerned, this can be quite significant. And as we see too with the aging population, that if people have limited physical or mobility capacity to get around, they're going to be homebound for most of the day and also not reach out to their family or friends for support to help, clean out or bring things, and that causes major problems.
May I add 2 cases from my personal experience?
Maybe go for it. Yes, absolutely.
In two homes where public health was finally called in because of the neighbors' concerns about rats and stuff, they found family members mummified in back bedrooms.
That's wow. I've heard of I've heard of a coyote, actually on a rural property where there were skeletal remains being trapped, but I haven't of actual mummy remains, that's on another level.
A
So,
son and a sister.
wow. I mean, when you read the resources, and I will probably not bring up the resources lightly at the end of this talk, but there are books and case studies that are very intense. Where where people are trapped in their homes, and people who pass away that they don't find for days, if not weeks. Just being able to get access in the home or not having contact. So yeah, that example, the after effect extreme, but as far as the time delays for people to find people in homes, that's not uncommon. So an eye-opening example, but a good one, which I think which you gave there, it portrays the picture. So what the media does not show accurate portrayals of hoarding. Obviously, they show hoarders, as you've seen. I'll just bring this up because they take the worst case examples. And when you're finding themes and trends, that can vary across age groups, across both urban or rural settings. But one thing they do not do in that show is show follow-ups of what happens after someone hoards. So if there's a clean out that happens, they're trying to help the person, they may not feel fully comfortable. They don't talk about the after effects and where people may re-hoard. So this is really the slide 2 of the psychological impacts of a clean out, and something all of you should be aware of. We think clean out's going to be the easiest solution, especially if someone older can't address it. This is a meta-analysis taken several years back, but it's pretty consistent on this level. Think of a 10-year accumulation of hoarding. This is the percentage of the home that has clutter and hoarding. Well, if you do an immediate clean out, and usually if that's within about a week or 10 days, that ServiceMaster, another company, comes in and does that, look at the acceleration from 0 months to almost a year. Past, this is 6 to 12 months, it should be, but almost a year. It not only hits, but exceeds the level of clutter and hoarding just within that 1 year after a clean out. The reason for this is if you don't address the psychological impact of someone that's had years of this dysfunctional thinking, they're just going to revisit and have to pack everything in because that's all they know. So if you're not addressing the underlying psychological mechanisms, as well as getting support from your team, this is just going to revisit and happen again. So again, clean outs are not sustainable. Sometimes they are necessary if someone is avoiding eviction. They have to be in their home, or there's a way that a family member can help them or move in temporarily. But long term, you're going to have to address the psychosocial impacts of this, because the mechanism, all they know, is tied to the items, not tied to what a clean living space should look like. So why this is so complex, specifically for the aging population, most cases are not reported to professionals. We think in the therapy space, okay, well, if we get referrals for hoarding, we can address this head on with the person. I can say in combination with private practice, those in the aging and memory clinic, those I've seen in primary care and consulted, and in the community, 90 to 95% of cases are either a family member or friend coming to help someone, or it's been a report from a utility person in in-home service, someone that's gone in the home, that they've seen a problem happen with this person. It's not going to happen very often that someone's going to voluntarily say, okay, I have a significant hoarding issue, I'm also going to need direct help, whether from my doctor, my therapist, case manager, someone that's helping. And so the second point where you really have to get disciplines involved is super important. Whether law enforcement, or again, a professional organizer, a clean out specialist, someone who is supportive from a cleaning company that knows how to do safety day clean outs, that becomes super important. I would not advise anyone, obviously, for a mental health provider, someone to go into the home and help assess how are we doing a clean out right away. It takes a lot of trust in building, but also safety based on with the home condition. And obviously, for legal and ethical reasons, if there's other people in the home, there's risk, but we're really starting to see this, come about in rural areas where there's a lot of challenges with just access for therapists or people that are coming out there and being able to work on this. So again, we're seeing a lot of disparities that are happening, and surely this is one of them is the geography of all this. So so as far as again the diagnostic criteria. And again, I'll just go over this real briefly too. Is the difficulty discarding, the need to perceive to save items, and the acquisition. So the discarding and acquisition combination is what's going to make this really difficult for people, where you'll have a criteria to make a substantial diagnosis for someone. And obviously, whether it's due to a medical condition or mental health condition, that's variable based on patient to patient. The specifier, though, is really interesting, and the DSM added this, whether there's excessive acquisition taking place. And if that's really hallmarked, then you know that there's a real safety concern. So if you see a hoarding disorder diagnosis, or if you reference DSM very quickly, anything that hits on this spectrum means that there's already a pretty big safety home risk that you have to assess much more. The insight part was really important. They added as a subtype because this was often glanced over, insight being good, poor, or what they call delusional. So the delusional insight, again, is not only am I hoarding, but it's okay. And why would you even interpret this as a problem? So it's full on denial from the acquisition, discarding, and even thinking that this is a problem in society to begin with. That's obviously going to take the most amount of long-term work, and where, again, a forced or necessary clean-out may have to happen if things are really spiraling downhill. So the ICD clutter hoarding scale, again, I'll send all of you a PDF for this. You can find this also on what's called the Institute for Challenging Disorganization, ICD. It's a great website. They've worked with the OCD Foundation a lot for hoarding treatment. These go based on 5 levels. So it crosswalks level of severity with categories of structure and zoning, animals, household functioning, health, safety, and any PPE equipment that they have to bring in. As you can see here, once it starts to hit level 3 at a moderate intervention, this is where you're starting to get smoke alarms, HVAC units, electrical outlets, things that are blocked that are really going to cause some safety risks. If there's animal hoarding, there's some sanitation areas. The household functioning is really important. And I think for anyone that works a lot with patients with fall risk, this household functional column itself could be a great assessment for knowing if there's someone that has multiple fall risks in the home and they're starting to work up these levels, what things are blocking or kind of going through this risk with doorways. Those who have higher levels of hoarding, they create what are called goat paths. So even if they're the tiniest paths within living rooms, dining rooms, kitchens, a highly hoarded home, they will find angles to still walk through. So it's almost like they're creating a maze, and they could have medications buried under there, or any medical equipment that they need to use. That's just going to be mixed in with anything else in their piles that they're using. I actually did an in-home assessment for a woman years ago with severe hoarding, and she had 2 of her cholesterol and high blood pressure meds under an enormous pile of clothes in an already hoarded bedroom. So she had mobility problems, and this was a huge risk going on. So again, this is just a really good scale to maybe reference and look at. So did anyone have any questions so far, or thoughts? I didn't know if this is helpful as far as for assessment wise, or being able to look at other things in the home. But
when you find this, I'm sure you're going to get to it, but I'm just waiting to, when you find this, what can you actually do? Because I'm remembering my 2 Chicago mummies, where I was on the Chicago blah, 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 aging something. And there was a lot of ethical, legal discussion about, but what if they choose? Can you, you know,
Yeah, yeah. And no, that's a great question. I'll get really the highlight technique I'll talk about is motivational interviewing. And I know all of you probably familiar with like stages of change and rolling with resistance for patients. That's been one of the more effective interventions for this population. And again, you bring up a great point too. When we want to give agency, communion, autonomy for people making decisions, but knowing that there's safety and home risks that are there, I often still go back to this level and say, if the clutter and hoarding does not meet certain thresholds for safety, risk of eviction, or zoning issues or health or safety, it can be controlled, although wanting to work with it. It's when it hits that level where forced cleanouts or safety days have to happen. So we always go back to the safety and levels of risk, because you've seen one hoarded home and clutter, you've only seen one. So that's probably the best curbside answer I can give. But we'll get to some interventions, because again, that's a great question you posed, maybe. The hoarding rating scale, if you're looking for specific assessments and this is a 5-item scale. I believe it's a PDF that's open to the public. Really, it assesses for clutter, discarding, acquisition, distress, and functional impairment. These are a few examples of questions that you can ask. You can even tailor this down if there's a few questions that you want to ask. If you in your encounters or you're working with folks, and again, if you feel that you're starting to get some red flags of what's going on in the home, accumulation of possessions, how much as far as mobility you're able to access things in the home, you're getting a home environment assessment just as much as you're getting a fall risk, or what people are being able to help you stay mobile and active. So really getting a good description of that is important. The home's assessment is a much longer one. Probably would not encourage that as far as in, outpatient or primary care, specialty care. But again, you can use sections of this for health obstacles, mental health, any endangerment to animals, to people, to others, and structure and safety. This is my favorite one, only because you can assign it to pictures. This is the clutter image rating scale. This is live. So if you Google clutter image rating from Frost, Gail Steckity, Tallon, and Renaud, you get to match what levels of hoarding in a bedroom, kitchen, and living room on a 1 to 9 scale would look like. So if you bring and literally print this out, you could just keep a copy in your office for life and then bring it out as a more pictorial. Really, when they're looking at a level 5 or 6, you can see where there's starting to be some, lack of floor space that's coming about. And that's not only in the bedroom. You can see this, sorry for it's fuzzy, but kitchen and living room. You can see at the 5 or 6 level, someone's at an 8 or 9, that's severe hoarding. And you can also see that not just for the bedroom and living room, in a kitchen, you have appliances, you have outlets, worst off, you have stoves. I've done a few in-home sessions where people have kept stacks of newspaper on a gas stove and have kept them there for a long time. So you have to have conversations, because people's reality orientation is not with safety. It's I have to store and put things there. So I would highly encourage, if you really want to know the insight of what level threshold, and print this out, a level 5 or 6 and higher on the clutter image rating can give people a sense of things. Again, they may not feel fully comfortable, may not look like their bedroom or living room or kitchen, but they have a sense or pictorial. Yeah, my place is looking like a 5. It's starting to get pretty bad. You'll have an idea as far as safety and fall risk in the home by using this. Great rating scale. For conducting a home visit, and if you feel like there are patients or even people in the community who necessitate one, and you're making referrals out to do this, they can be effective, but as I mentioned, you have to get buy-in. Home assessments and an initial assessment should do nothing about clean out. Professional organizers, those who do site visits, tour the home first, or apartment or condo or living situation, to figure out, what am I looking at, just to get a sense of joining with the person. Sometimes when people do home assessments, it's been months, if not years, that they let someone in their home. So it can be terrifying, highly stigmatized for, oh my gosh, what are they judging we do? So sometimes it's just entering 2 or 3 rooms. You get permission if you want to get, any paper or tracking notes. And if you collaborate with those who do a home visit, they can give you kind of an assessment back. But one thing that really goes sideways for home assessments is people have the need to clean out right away. That's why if someone that needs a major clean out or a higher level of safety, never rely on a service master or a large clean out, even though they do good work, as a first point of contact. You want to see if there's a therapist, an in-home specialist, a professional organizer that can go and do these type of clean outs. Now, they're wonderful for professionals. The huge problem is there's not many of them. So, you have to use your resources wisely. So it's also done by as few people as possible. Highly discourage or against throwing a student, fellow, or resident doing this for the first time. Hey, this could be a good field trip for you to do. Not a good idea. If you're doing a home assessment, again, this is someone's home and property. You really, really have to have skills of people going in, of knowing the tempo, what to ask questions, not to touch anything. We'll talk about that balance, certainly in a little bit when we go on. So, yeah, Miriam said the image looks like nursing home rooms. That's true. And actually, it's funny you mentioned that, because I really think nursing homes should probably use more of these rating skills too, and try to, assess for that. So managing initial reactions, for anyone that does home visits, and that's a good point, in nursing homes, long-term care facilities, you want to avoid judgments. And always, if you're talking with people or those going into places, and especially if you're working with caregivers or family members, you want to avoid, gosh, what a mess. That's a disaster. Boy, this is just crap. What is this? That's not going to go well. It's personal items, personal things to people. They will lose trust. You got to have a good poker face. One of the toughest things for clean out specialists and people that do in-home visits is when there's odor, there's toxins, there's things there. Even if you have a mask or PPE equipment on, it can be pretty pungent. So again, when you consult as a team, making sure, people are trained to do that. Matching the person's language, even on how to talk about items. I'd say even in encounters, when you have patients who talk about their items and have problems really throwing away things, you want to be empathetic and really respectful of it. And we could generalize and say, oh yeah, again, the receipts or those papers, you could throw that out easily. I mean, there's ways you can do it. It's not so easy. Every single item counts, and people spend hours, weeks, and months, sometimes years of their life obsessing around what to do with these items. Avoid touching objects. I would say one thing, and actually we did know of a primary care place in around the country, I believe it was in the Northwest, where they had patients bring in an object or two to their physician, to their therapist, where tangibly they could talk about it and kind of get the ball rolling on how to discard. I'll have a video, if we have a little bit of time, that talks about the downward arrow method and technique about there. But again, even if you're not doing in-home clean outs, anything that patients, family members, caregivers talk around hoarding, be respectful of the language. Again, it could be some really bizarre things that are happening in the home that they're accumulating over time, items you would never want, that you would think in your mind, if I had an extra hour, I would drive to their place and throw this in the dump. So there's a lot of temptations, but again, the sensitive language is really, really important. Building trust, again, initial safety. When you're doing clean outs or when you're having sessions with patients or especially family members, avoid the fate of where possessions would be, and discuss this and really get input from, multiple professionals, working on this team together. And imagine yourself in the client's shoes. It's really, really frustrating and difficult, for many of the physicians on the call. An older adult has been accumulating for decades and feels a lot of guilt and shame. Like, I would never let you in my home, but even just talking about it is embarrassing. And sure, they know that there are health risks associated with it, but even just talking about the stigma of it becomes really, really difficult. So make sure you keep that sensitivity there. And then dealing with resistance, I'll talk about motivational interviewing being really one of the main interventions for this type of work that you can do. But again, your goal is really to resist trying to, go against or denies people's, resistance or painful feelings around items. You really have curiosity and empathy before you get into any interventions that are taking place. I'll also say family members have a lot of reactivity and beliefs. You're not in their shoes because they live with it on a daily basis, or they come to the person who's hoarding on a daily, weekly, or monthly basis. So before it gets into a full-blown problem, families need to know how to sensitively, communicate and find strategies as well. But it's oftentimes the family members that go to, the therapist or the doctor, or find resources of this first before the person that is hoarding. And I would say, if the person's really struggling, they will have some mental health challenges too, for the caregiver or primary person who's also in the home. So if they need to seek out their own, therapy or behavioral health, that's often really, really helpful and impactful too. When is it reportable to authorities? Obviously, reporting standards are pretty consistent, obviously, with, a lot of other health topics that you'll have in practice. So if there's a child or minor that's endangered, obviously with elder neglect and elder abuse, this comes into play quite a bit. This becomes very tricky of the person who's hoarding, who's older age, but may have a older age person in the home as well too, who's neglected maybe of food safety, other lifestyle factors, ADLs. So, you want to keep those in mind too. People with disability, people with dependencies to need to get out, who may be restricted from that. That could cause a major legal ethical challenge coming about, and starting with animal hoarding. If animals are in danger, and this becomes a legal problem, it's something that you definitely want to keep on the radar. So, mandated reporting laws that we have as mental health professionals, certainly for medical professionals, for community health workers, the standards of what you need to report are consistent, because again, if there's legal and safety risks that can happen, it's our duty to make sure that we, protect people that are in the home. And again, on the side here, we go back to health, the obstacles and structure. Going back to the safety level is really important that we assess that continuously. So for sake of time, I'll just narrow down on the treatment and strategies. I don't know how many of you are familiar with motivational interviewing. Have any of you used motivational interviewing in practice? Or I highly doubt for hoarding, but maybe for alcohol, substance use, or around mood issues, or working through pain. Has anyone done any MI work?
I tried. I don't know if I did it right.
Okay. All right. The confidence versus competence debate. I know therapists talk about that too. So that's right. It's good. Anyone else ever try that, or use kind of styles of motivational interviewing? I don't know if anyone's been trained to do it either, but yeah, the traditional work is really from Miller and Rolnick around alcohol substance use, but really, people, working through, sobriety, working through change. And so, what we've really seen too is for people who want to get from pre-contemplation to action, to want to discard and not acquire, those two symptoms, the wheel of change can be really, really effective. You know, a lot of people are going to start, the vast majority, between pre-contemplation and contemplation on the first two stages here. So, you know, feelings of, you know, I have no intention to change, to, you know, I know it's bad, I just don't know how to go about it. Really, when you start getting into preparation, that's where a lot of the in-home work, or people that can start to do more cognitive behavioral work, or motivational behavioral strategies, that comes into play. But, you know, a lot of times therapists and even if providers hear this, they're going to be stuck in swimming in the pre-contemplation, contemplation side of the pool for a long time. So just know it can take many sessions before people prepare and know it's not only a problem, but how they can make changes across time there. So, you know, expressing empathy, so being able to, you know, find acceptance, working with someone, developing discrepancy. So, you know, people know the difference between the differences of their current situation and where they want to be in the future. What's not working, excuse me, what's not working well, and in the future, how things could be different if they change. We often call that the miracle question in solution-focused therapy. That's really neat. We say that a lot in behavioral health. You know, 6 months from now, if you were to picture one room in your home looking ideally what you want to, describe for me what that would look like, right? It gives a positive view that they may never thought of, wow, well, you know, I'd actually like it clean near my bed so I can get into my bed. I like my bed cleared off. I like be able to look in my mirror. So, you know, getting dressed or being able to see myself in the mirror in the morning, that's actually something I'm looking forward to. So again, giving more of that solution-focused motivational mindset's important. Again, we talked about self-efficacy, giving responsibility for people to work on things, but the rolling with resistance is really going to be one of the hardest skill sets to work with. I know all of you, the geriatricians, roll with resistance for patients on a daily or weekly basis. So you've already had that in your back pocket for since residency. But you know, for this population, when you have a talk around items being personal for someone versus kind of being a diagnosable disorder, there's a middle ground you have to get to. So, you know, anticipate resistance and being okay with it, and show curiosity for that population, because it's really important. So I'll skip that just for sake of time. CBT has often you know, been a really good strategy as well too. So developing in elements of motivational interviewing, but also if there's overlapping OCD, anxiety disorders, you know, how people can manage their beliefs and meanings around items, how they can work around maybe discarding 2 or 3 things per week to start out and accumulate and increase that. So again, hitting the excessive acquisition and difficulty discarding points. You want to make sure you're really reducing those behaviors over time. All right, I think I'll have a little bit of time. We have 10 minutes, so I might only have like 2 or 3 for Q&A, but I'm going to show the downward arrow video. Hopefully the sound works for this. This was from Randy Frost from Boston University. He's just doing a downward arrow method with a patient. So you'll see just a brief video. She has difficulty discarding things, especially that were handed from her sister. A family member had passed away, so she's accumulating a lot more from her family. You all can hear it. If you can't.
Okay, but today let's just focus on 1 or 2 things that are problems for you. Can you pick something out from the things that you brought that you can't get rid of, but you know you probably won't really use? Now, remember, this is an exercise, and the purpose is not to throw things away, but just to learn something about your attachments to them, okay?
Okay, how about this purple shirt?
Okay, that looks great. Let's try what we call a downward arrow method to look at the way you think about this, about getting rid of this shirt, so we can better understand how attached you are to it.
That sounds okay to me.
So what comes to mind when you look at this shirt?
Well, I got this shirt for Christmas 3 years ago from my sister, and that was just a really good year. I was still married, and I just remember feeling happy. So now, whenever I look at this shirt, I remember there was a time in my life when I felt that way.
Oh, okay. Okay. So it sounds like you have a strong emotional attachment to the shirt because it brings back good memories. If you were to get rid of the shirt, what thoughts would you have?
Well, I'm worried that I wouldn't be able to remember that Christmas and that happy time in my life as well if I didn't have the shirt to remind me. I'm also worried that my sister is going to expect me to have it. She gave it to me for a gift, and if I get rid of a present she gave me, it'll be like I didn't appreciate her gift. She might ask me, "Where's that purple shirt I gave you?" or "Why don't you ever wear it?" And I think she'd be very disappointed in me if I got rid of it.
I see. I see. So what would be so bad if your sister was disappointed in you because you got rid of the shirt?
Well, if she was disappointed, I know that I'd done something to upset her, like I had betrayed her somehow, and then I'd feel like a bad sister.
Oh. And what would be the worst part of that?
Well, if I'm a bad sister, she won't want to talk to me anymore because she won't be able to trust me. We usually talk a few times a week, and if she doesn't want to talk to me anymore, I'll get really lonely.
Can you tell me more about how that would feel?
Well, I'd hate feeling all alone because then I'd feel like I don't have anyone in my life that's there for me. And if she abandoned me, I'd be all alone and depressed.
I see.
Though I still thought it might be a good idea that I somehow let my sister.
Can you tell me now your reactions to the experiment?
Well, for a while, I still had the feeling that I somehow let my sister down and that I should have worn the shirt more than I did. So I decided to call my sister, and I told her that I'd given the shirt away.
And was your sister disappointed in you?
She had forgotten that she'd even given me the shirt because she never saw me wear it.
What else happened?
Well, I was surprised. I could still remember that Christmas and how good I felt back then, even without the shirt to remind me.
So on a scale of 1 to 10, how badly did you feel this week?
Well, when I left last time, it felt like a 5 or a 6, but now I'd say it's a 1 or a 2.
So what did you learn from this?
Well, that the shirt wasn't as important to me as I thought, and even though I don't have the shirt, I'll still have memories of that special Christmas. Also, since I gave the shirt to Goodwill, I think someone who needed a shirt probably got it, and that's a good thing for them. And maybe it gave someone else a good memory. And my sister is actually proud of me for getting rid of something that was difficult. I don't understand why. I thought it would be so horrible.
Okay. So for sake of time, I'll run through. But you could hear obviously the downward arrow and some of the cognitions and distortions, and that's very, very typical, right? Of I just feel a lot of distress if I feel I'm going to get rid of it. Someone gave this item to me. Inheritance that comes into play a lot, and the perceptions that people that hoard over time is others will fear if you do something with the items, they're going to get mad or upset. In this situation, her sister didn't even know she gave her the shirt, right? So the discrepancy between that huge anxiety of what the world and others think of that person and the reality can be stark differences that take place. So the only other point, and then I'll just skip ahead on slides, we can give you a copy of this too, is just the subjective units of distress. This is not only helpful for people that go through like acute anxiety, but as far as the anxiety of giving away items, donating or discarding items on a 0 to 10 scale, usually people that are about a 6 or higher on these two levels, there's a pretty extreme need. And I think those that consistently rate items or difficulty discarding at home, you're going to find a lot higher prevalences of those that are clutter or hoarding within the home. So I will, just for sake of time here, skip ahead. The collaboration with related professionals. Again, I mentioned mental health professionals, housing authorities. They're great resources, especially if you have patients that are in, multi residential units, really making sure that things are safe for property managers are aware of any risks. Again, professional organizers, animal control, protective services, make sure that you have resources, out there, if you hear of a situation that takes place. But, again, we're hearing a lot more of this in facilities, not just in homes there. So the takeaway tips for hoarding work: assess, assess, assess. I would say if, the next time you have patients who talk about fall risk in their home, there's other worries you have about just home safety, ask a few of these hoarding questions. Talk about just the dynamics around, what's in their home. Are they still feeling comfortable of, discarding things or keeping walkways or places safe? So really talking about that. Keep the collaborative list of resources available. And so once the physical space is safe, declutter can be the main priority. But again, using an organizer or clean out if needed, make sure a person is prepared to do that. And singular focused, one part of the home at a time, and really being sensitive as far as the communication for people who are on the spectrum or in this population. Resources, there's a lot out there. There's still elements of the hoarding project, even though that group has dissolved, but that's actually formed in as part of a hoarding Facebook page. So if you're on social media, there's some great connections on LinkedIn and Facebook. The International OCD Foundation, the Mental Health Association in San Francisco, ICD, has some great information. There's also support groups out there for children, caregivers of those who hoard as well. Here are some of the reading resources. I think they have a few case examples. Maybe it may not be at Miriam's level of the Mummy situation, but as far as the actual, some very stark examples of people, trapped in their home, with stuff buried in treasures, they talk about that. I've given talks on ambiguous loss before, but I'd say again, trauma, loss, grief, divorce, separation, relocation, huge factors that contribute to hoarding in the aging population. So some good resources there. And finally, I'll put in a plug. We have tentative dates, but if any of you have a Friday full day or half day in April open, we're deciding. We are going to be doing, as part of our SLU Spring Caregiver Conference, the whole day on hoarding and clutter. So we're going to bring a bunch of professionals, maybe consider this a primer for the conference. We're going to have speakers and panelists around the country. It's free for all students and faculty at SLU. So if you want to join on Zoom for half or the full day, we'll be putting some press out probably closer to the end of the year, beginning of next year. So keep that as a placeholder. So that's all I have. Open to any, I saved 0 time for Q&A, unless we go over time and if people have a few minutes for maybe questions or just general thoughts. Hope this may be helpful for some of you as a refresher.
Thanks, Max. That was great. I was curious about your comments about organizational experts coming in to reorganize. Is that something that could be a temporary solution? I mean, if you could hang or organize or fold or put things in places, you might actually, in some cases, alleviate at least safety issues. Is that successful? Do people resist that just as much as discarding items as just hanging up, organizing, and shelving things?
Yeah, good question. The effectiveness of organizers can be very successful. But again, as mentioned, the trust of step one, getting people in the home, people who are trained, and also people that have the experience being able to talk around the mechanisms of the hoarding become really, really important. So yeah, I think once you gain trust from a variety of people of entering the home, and again, mental health professionals, certainly that have done in-home work, no, I mean, I've done little and others have done a lot more than I have, but you have to get the trust and safety down before doing that. But organizers are really the ace in the hole for this when you're doing in homes, but definitely do the stepwise approach before you do a full clean out. That's one of the biggest takeaways. You saw that rise in 10 years in post clean out. it's bound to happen at some point.
So Max, given that most of us will never be in someone's home to get the full effect of all of this, probably most of the information could come from a family member. What do we do in those cases?
Yeah, so I think if there's information during appointments or during phone calls, being able again to have the sensitive language and to coach family members on how they can communicate and be supportive to someone. We often even educate the caregivers and family members to use forms of motivational interviewing. So
That's good.
yeah, so kind of ways that they can gain more confidence of, how can we help and support maybe small sections to start in the home. Or again, as far as the health safety, to focus on that first before the actual discarding is important, so that the walkways open from 2 feet, to 3 or 4 feet, even doubling that gives more of a sense that people wouldn't trip or fall as often in the home. So that becomes there, and the resources in the community again, where, whether it's a professional organizer, a case manager, someone that you can call, that they can rely on becomes super important. So
Thanks. Great presentation.
yeah. I know I kept everyone over time. I appreciate within the chat some of the information and comments too. So yeah, I would just say final thing is, just hopefully with this, know the connection, again, between home safety and this. Look up the clutter image rating, the 5 levels of safety. I guarantee you, if you know more of that and what's in the home environment, you'll get a better picture in a lot of your encounters talking with family members, a vision in the home of what you're dealing with. Because there's a disconnect between what we think of what's diagnosis, and this is one element that you have to know home symptoms and issues of what's happening. So
Can those be updated in Epic? So they could be useful in the clinic?
oh, you mean like the information resources?
Well, the little checklist things like we have like the RCS and the slums and the.
Yeah, not a bad idea. Yeah, I mean, we can certainly push for that. I mean, if we can get a very, very brief, even downsized version of the hoarding rating scale, just 5 item, even if there's a 2 or 3 question of that to the prompt, I think there could be great utility.
Make it so.
I knew there was going to be I'll go to someone to push that through, but no, you're right. That's a prompt that I've always thought in primary care and geriatrics. If you're dealing with, home safety assessment, could be helpful. So
Thank you.
yeah, thanks. All right, you can officially cut me off now. I know I kept you way over time. So, all right. Well, thank you, everyone. I appreciate it. And thanks again, Matt, for the coordination on there. I'll send more information out to everyone interested in attachments too. So appreciate it.
Thanks, Max.
Okay. I'm logging off. I'll see you later. Thanks again.
Bye.